Right, so let's carry on from where we left off. This is Maz, my girl cat. She rules the house. Yeah, told you, it's the woman in my family. Okay, we are talking now about the gynecological history. So this is distinct from what you elicit about the presenting complaint. You are going to ask some of the gynae questions about the presenting complaint, but these are just other things that would go in there. That is a picture of me at the 4,000 millionth Vula online learning tutorial thing webinar. Yeah, so I hope all that learning has been worth it for you. Right, so in your gynae history, you want to know every possible thing you can know about the periods, and you also want to know about other reproductive and sexual health issues. So if we talk about the periods, if the cycle is now abnormal, but it was previously normal, you need to establish a baseline about what was normal. You need to know menarche, so the age of onset of menstruation. And you need to know the duration and pattern of the normal menstrual cycle. And in the reproductive age group, you need to know when the last menstrual period was. And sometimes you need to distinguish that from when the last normal menstrual period was, because that can give you an idea of how long an abnormality has been going on. And then if we look at reproductive or sexual health, contraception is in bold and highlighted in pink. If you haven't already asked about this, this is absolutely crucial because you'll come to learn in the section about family planning that contraception is one of the most important health revolutions for women, and you need to ask everything about that for every woman patient that you see. You need to know whether your patient is sexually active or not, because that has diagnostic implications. And a sexual history where relevant. So you're not going to ask an 85-year-old woman who hasn't had intercourse in the last 30 years about her sexual history because it's not relevant. But if somebody is having symptoms that might indicate issues of a sexual nature, like pain on intercourse or an STI, you might want to know a little bit more. You also want to know whether they've had a history of an STI before, because that's got potential implications. And just from a pure public health point of view, you want to know when their most recent HIV test was. And another big revolution in women's health is pap smears. So all women are entitled to pap smears. You'll learn more about that. You want to know when your patient's last pap smear was and if she's even had one. Now, big sidebar on contraception, and I thought that it was appropriate to put this as my daughter. And I was able to decide when I wanted to have her because of contraception. So I was very busy with career things, and then I decided, okay, it's time. And that is the kind of freedom that contraception provides women. So if somebody in reproductive age is not on contraception, there's a big fat why not attached to that, because it is such a life-saving, liberating women's health revolution. So if someone is not on contraception because they want to fall pregnant, great. If they're not on contraception because they're not sexually active, great. Those are two answers that I'm happy to accept. But I will not be satisfied if someone tells me that they are not on contraception because they had bad side effects, or because they couldn't access the service, or because they are under the misapprehension of myths and misconceptions in the community. So if any of those things are true, if someone has side effects on one method, there's lots of other methods that you can try. If access is an issue, there are much longer acting ones that are potential. And myths and misconceptions sometimes just need to be dispelled in order for women to use the right contraception. So this is a crucial moment. If you've got someone who is sexually active but isn't on contraception, that person is going to fall pregnant unless they're on contraception. So it's your job to make sure that they are on a method that works for them, so that they don't have an unplanned, unwanted pregnancy. Now, older women, now that is my great auntie Tasha Altushka. She is from the Polish Jewish side of the family. She looks utterly terrifying. I would not want to meet her in a dark alley. But there she is as an older woman. You're going to ask different questions of older women than you would of younger women, as I said. So perimenopausal, which is your sort of 48 to 52 group, you would want to know when their menstruation started, because you are assessing their estrogen window, and you're going to learn more about that when we talk about endometrial carcinoma. And you want to know about any of those pesky menopausal symptoms. You also want to know whether they have been on contraception or are currently on contraception, because contraception also has an impact on your estrogen window. And if they're currently on contraception, you might need to change it because of age and risk factors, etc. So you're asking these questions because of quality of life issues. If women are experiencing, and they might present to you, this is a presenting complaint of women in this age bracket with absolutely intolerable vasomotor symptoms, the hot flashes, you can offer them HRT, provided they have no risk factors, which you will learn about. Postmenopausal women, so these are now women who are several years beyond, or decades even beyond, when they stopped their periods. You want to know about menarche, and you want to know when they went through the menopause. Again, it's that estrogen window that we're going to learn more about. You also want to know whether their estrogen window has been interrupted by prior contraception. You want to know if they've ever used hormone replacement therapy. So that woman who comes in with the severe climacteric symptoms who gets prescribed HRT, you would want to know that about a history if she comes in much later on in life. And you would want to ask about urinary symptoms, because issues like uterovaginal prolapse are a lot more common postmenopausally. And you'd want to ask about GIT symptoms as well, because there are certain cancers that are linked to GIT cancers, or gynae cancers that are linked to GIT cancers. Okay, so those are questions that you would not really be asking younger women. Okay, obstetric history, that is MAS on top of the baby, who was obviously still inside. So obstetric history is usually much more relevant in women of reproductive age. So you want to know gravidity, which is how many pregnancies have there been, and parity, which is how many deliveries have there been. You want to know about any miscarriages and where in the pregnancy those miscarriages happened. And you want to know whether the deliveries were a vaginal delivery, a Caesar, or instrumental. You want to know about a history of any ectopics or termination of pregnancy. I would not go into this much detail in someone who is postmenopausal, because most of these things are no longer going to be relevant. What is going to be relevant postmenopausally is if someone has urinary symptoms, then you want to know how many normal vaginal deliveries, because the more normal vaginal deliveries, the more chance of prolapse. And you'd also want to know about any instrumental deliveries. But the intricate details of every single pregnancy are not going to be relevant in your much older patient. Those are going to be more relevant in women who are still in the childbearing years. I have no idea who this woman is, but she was also in the family album, and I know where I get my hair from. She's also from the Polish Jewish side. I have no idea who she is. So you want to ask on previous medical and surgical history. You want to know if there are any comorbidities, admissions, or chronic medication. Avoid, and this holds for all of medicine, don't just ask, do you have a medical history? Because patients don't know what the hell that means. You need to ask them about specific common illnesses. And I always ask whether people have been admitted to hospital before, because sometimes that is significant, but it's not in their consciousness about the current complaint. And you also want to ask about any chronic medication. And then any major surgeries. If somebody had their tonsils out, not relevant. What is relevant in terms of surgical history is if they've had pelvic surgery before, and that would include a cesarean section, or whether they've had abdominal surgery before, because those might have implications for certain diagnoses. And then you always, in every patient you're ever going to see ever, you're always going to ask about drug allergies, because when you manage a patient, a lot of the time you're going to be prescribing medication. So you always need to know that. Okay, then family history. Now, here is my fantastic stick drawing of trying to keep you relevant. So a relevant family history is something that affects a person's first degree relatives. Usually, mostly the women are relevant in gynae. So mothers and sisters of the patient. There are certain genetic or conditions that are genetically linked. So there's some breast cancers that are genetically linked. Ovarian and colon cancers can be genetically linked, and polycystic ovarian syndrome is a genetic disorder. So I don't want to hear, so starting from the left, your grandmother's best friend, sister's pink poodle's hamster had TB in 1965. That is not relevant. It's got to be relevant to the presenting complaint, and it's got to be a close enough relative to actually make it have a bearing on the potential genetic influence. Okay. And then finally, we have the social history. So living circumstances, who is she living with? What is the income like? We're going to talk a lot about relationship issues in terms of intimate partner violence, any stressors at home, and then you want to know about smoking, alcohol, or any other substances. Now, this is another one of the family chronicles. There's my maternal grandmother again. This is so complicated, this picture. Oh, and the fashion, even worse. That is my grandfather. So that's her ex-husband. They were divorced. That is her then current husband. They're all out together. Who knows? There's alcohol going on. There's smoking going on. This is just to remind you to ask about these things. Now, this grandmother, both of these husbands, my grandfather and the subsequent husband, they were both awful relationships, absolutely fraught. And that probably had consequences for my grandmother's health. She was a smoker, which definitely had consequences for her health. So this is just a visual to burn into your retina. Oh, wow. White people in bad fashion in the 60s. Ask about the social things, the things that are surrounding that patient, because patients are not, no person is an island. There are other things going on that influence their health, and you need to know about those. Okay, so that is it in terms of the gynecological history. The next set of slides that you will go through will be issues around examination.